So thank you very much, and welcome everyone. Good afternoon. Yeah, so I'm talking about something that seems to be very, very boring. So first of all, these laboratory values are very established and old things in medicine. So people normally now are looking for like omics data and proteomics, genomics, transcriptomics, metabolomics, and then even more boring standardization. But I hope I can convince you that this is not just boring, but has high potential and also for global health, and there is a need for it. So what I'm talking about, maybe most of you have seen something like this already, at least when they went to the doctor and had taken their blood from them, and then you notice this is sent to some lab usually. And though this is a German one here, so this is a real lab report or laboratory findings. So you see here some analytes. This, as I said, is all German, but at least this one you can see the 6,1-HB hemoglobin. This is like, yeah, very well known. This is like the for the blood, for the oxygen transport in the blood, it's important. And you see on the very right, you see the corresponding measured value. And then in the middle, you see always something like a range. So here for hemoglobin, it's 12 to 16. So this is whatever it calls is the reference interval. So whatever you think it's, I will explain it in detail later on. So this is the kind of normal range, whatever normal means. So here you can see from this patient, the value 14.5 for hemoglobin is in the normal range from 12 to 16. And sometimes you see some pluses or minus behind. So minus means, for instance, the eGFR. This is some kidney value in some sense, or a computed kidney value. It's a little bit below the range, so below 90, which is the lower limit, and so this is why it's a minus, and then the kalium is a little bit increased, also speaks in favor for some maybe small problems with the kidney. So this is what you see, and this is the lab report. And now I just give you a brief introduction what I'm talking about. So I will explain later on. I've shown you these reference intervals and laboratory analyzed findings, and I will talk about some pitfalls. So I will just give you some information about what can go wrong, because this is the most important thing. And then I can explain why we want to standardize these laboratory values, not only we, it's Germany and worldwide. And one approach is the zlog-value. There are others, but I think this is the one that is at least mostly used, and we have introduced it, and the basic idea behind. I will show the applications and benefits, and I will conclude with some remarks at the end. So reference intervals, you might wonder how this normal range is defined. So the reference interval is defined as if you take a healthy population and you order the values to cut off the lowest 2.5% and the highest 2.5% values, and this is the reference interval. This is how it is defined. Of course, if I talk about population, I do not mean just the whole population. It usually depends on age. So there are different reference intervals for older people, for children, for babies, and so on. It can also depend on the sex. So there are some values, like even this hemoglobin is for women is usually a bit lower than for men. But it can even depend on cultural factors. If you look at certain liver values, you will see that people who drink alcohol, I'm not talking about alcoholics, I just talk about, let's say in Germany, about those people who drink their, what we call Feierabendbier, so drink a glass of beer or once in a while in the evening, or enjoy a glass of wine for dinner, then you will already have slightly changed liver values. You can actually notice this. So you don't have to be an alcoholic to see this. Even if you drink like every other day a glass of wine, and it's already noticeable. And these reference interval can also depend on the lab. So in principle, the labs have to determine their own reference intervals, or at least to check them. How to there's something. Okay. How these reference intervals are determined is a completely different story, and it's actually quite complicated, because what is a healthy population? How do you acquire a healthy population, especially if you talk about older people? Like reference intervals for people over 80, you seldom find people who have who are completely healthy over 80. But this is another story. There, as I said, could give another talk about this, but it's not global health. This is another issue, and actually a statistical issue, and this is why I'm also interested in this. So, and there's another thing: you should not confuse reference intervals with so-called decision limits and alarm limits. So, decision limits depend on the purpose or the application. So, for instance, if you go to blood donation, they also measure the hemoglobin to check whether you have enough hemoglobin in your blood. And if you do not have enough, you are not admitted for blood donation on this day. This doesn't mean you have to go to the hospital immediately and get some blood transfusion. It's just a very, let's say, conservative limit that they put there, so that they don't get into trouble. Does not mean that you really have problems or anything like this. So this is why they put the decision limit quite high there, and don't take people who might have problems after blood donation. So this is a decision limit, and depends on the application. So if you want a decision when you give a blood transfusion to a person, of course the limit will be completely different to that one. And alarm limits are those limits that are really critical. So in this case, if some value is below or above the corresponding alarm limit, then the doctor in the lab has to inform the treating doctors immediately. It will not just send a report; they have to call them directly, because this is a really life-threatening, could be a life-threatening state of the patient, and it's alarming. So we are not talking about this. We're talking about, in some sense, well-defined reference intervals, although it's not that easy to determine in principle the reference interval. But this is another issue, as I said. So let's have a look at some pitfalls. I'm talking now about small country, Germany, not about global problem. But when you see this problem even in Germany, then it has also to do with the history of Germany. You can see what happens if someone moving between different countries. So a pediatrician from northern Bavaria normally received these laboratory findings from a nearby lab in northern Bavaria. And then, for, I think, cost reasons, he changed to another lab nearby in Thuringia, which is another German state north of Bavaria. So for him, it's like the same distance as the other lab. So he gets the results very quickly. But what you should know, if you're not from Germany, so Bavaria belongs to the western part of Germany, and Thuringia is the eastern part of Germany. So so in Germany, the old lab in Western Germany, they used for hemoglobin the old units, gram per deciliter. So, and the reference number was 12 to 16. In East Germany, before Germany was unified, they used the so-called SI units, the standard units, which are micromole per liter. So, and this is slightly different. So the reference interval is here 7.5 to 10. So the factor to come from the old units from gram per deciliter to micromole per liter is just 0.621. Unfortunately, the doctor did not look at this. So he saw a value of, let's say, 8 or something like this, which is in the normal range for the new units, but which is quite low for the old units. So the baby got more than one blood transfusion before this mistake was actually noticed. So, of course, if he had looked at the reference interval, he would not have made this mistake, but it happened. So you can see it would be nice. I mean, if everyone would stick to standard units, then these problems would not occur. But this is at least now not the case in Germany, and also worldwide not the case. So you can imagine if you travel from one state to another state in Germany, such things can happen. And now imagine if you travel from one continent to another continent and you want to take your lab findings with you. Well, have fun. Then you have to think about other pitfalls. For instance, we have now this so-called point of care testing. So which means that we have now devices, the same applies to hemoglobin, where you can actually get results immediately. So if you go to blood donation, it's not that like they take a drop of blood from you and then they send it to a lab and you have to wait there for some hours and then they get it back and they just put it into some small point of care testing device and they get the value within a short time, within seconds or a minute. And there are many values that can these point of care testing devices can measure. The advantage is that you get the results more or less immediately. But of course, there is usually less precision and sometimes even the technology, because it's just a small device, technology for measuring is quite different. So if you, for instance, take calcium, so in the lab, they measure the total calcium, but which is quite complicated from a, let's say, chemical or measuring point of view. So it's easier to measure the ionized calcium. And this is what the point of care testing does. But this leads to different reference intervals. But if you don't look at what is there, you just look at calcium and you might be confused with the value. So you have to know this. Then let's say about let's talk about history. So if you think now, well, you might be young now in your 20s, and now we record everything electronically. We talk about this electronic patient file in Germany. And so then when you are like 60 or 70, the doctor wants to check whether your values have changed drastically or whether you always had certain values increased or in some other range. But actually in let's say 40 years, there might be other technologies. So for instance, until the 90s, creatinine, another lab value, was measured by the so-called Jaffe reaction. But this does not react only to creatinine; it reacts to some other things as well. So, and nowadays there's some kind of enzymatic method that is used, which is more targeted to creatinine, and it yields 20% lower values. So this means you cannot compare, or you can compare the values from like 30 or 40 years ago, but you have to take into account that they are 20% higher. You have to know this. But imagine a young doctor might have never heard about the old method and said, oh, this patient always had high values when he was young already, so no problem when he has high values now. No, sorry, he didn't have these high values. Yeah, so this means yeah, you cannot expect the young doctors to know the old methods and to check all these references. So these are pitfalls, and this is why there's an aim to standardize these laboratory values. It means they should be interpreted in an easy way. You don't have to look up how did they measure this 40 years ago, and also, you don't have to be an expert for all these laboratory values, for all these analytes. They should be understandable and interpretable worldwide and lifelong. So this is the goal. Now, let's see, how can we come to some kind of standardization? So the idea is that we want to get independent of measurement units, independent of the age, of sex, whatever. So actually, we want to get some standard values. And so I come to another topic which is quite interesting for me as a statistician. Might be not so interesting for you, but it's also a little bit interesting from the medical point of view. So how are laboratory values, at least of healthy persons, usually distributed? So you often find, or not often, some values like this hemoglobin, you find that they are follow like roughly a normal distribution in a certain range. And yeah, but you also find values that follow more like a skewed, right skewed distribution. Many of the values, yeah, most of the values are actually follow more like this kind of skewed distribution, which could be a log normal distribution. And there's also, if you look at the blood, there is a probable reason for this, that you have some values following a normal distribution and some values following a log normal distribution. So if you go back to the hemoglobin, this is something that you really need in your blood. This is important. It's not good to have too much of it, and it's not good to have too less of it. So you have to be, it has to be controlled by your body in a very narrow range. So this range is not close to zero, it's quite far away from zero, and this follows a normal distribution, therefore. Then there are many things in your blood that are measured in laboratory that are actually don't have to be in your blood. These are often like some proteins that are products when cells die. So when you have a heart attack, heart muscles die, and you find actually proteins from these cells. So they are just transported away. They are not necessary for the blood. Just blood transports them away. Of course, you always have some cells dying, so you have always a small amount of these proteins in your blood, but they are not necessary. So, and this is why you often have this right skewed distribution. So you have a small amount always there, sometimes a bit more, but it's not controlled. And actually, if something happens, then you get really large values. The same applies to other organs like liver values and kidney values and so on. So if you distinguish between values that need to be in your blood, they are often usually normally distributed, and values that are just like, yeah, transported by the blood but not necessary, they often follow a log normal distribution. And so then you should decide which values follow normal distribution, which values follow log normal distribution. Some people say actually it doesn't matter whether it follows a log normal distribution or a normal distribution. So now if you look at another log normal distribution with another parametrization with other parameters, then you can generate this blue curve. So you can see this is a log normal distribution, which looks more or less as the black normal distribution. I think you can almost not distinguish the blue and the black curve, only slightly. So this means actually if you have a normal distribution that is quite far away from zero, or a log normal distribution that also is quite far from zero, they look very similar. This is also well known in statistics, even mathematical proof that in some sense a log normal distribution can converge to a normal distribution. So this means if I treat all distributions as log normal distributions, we might not make a big mistake. So even if I consider the normal distribution, the black distribution, as a log normal distribution, and take and transform it so that like a log normal distribution, I will not make a big mistake, because it looks almost like another log normal distribution. So this is why this z-log value always applies a logarithmic transformation to the laboratory values to achieve an approximate normal distribution. As we have seen, it doesn't do much harm to, at least to those normal distributions that are far away enough from zero. And then we normalize this log normal distribution based on the reference interval. So if we transform the reference interval with also with the logarithmic transformation, the quantiles are transformed. So, and based on these quantiles, we can actually compute the parameter of the corresponding normal distribution and transform it to the so-called standard normal distribution. So a normal distribution with mean or expectation 0 and standard deviation 1. This means after this transformation, the laboratory values, the transformed laboratory values should follow, for healthy people at least, a standard normal distribution, which means the reference interval of the transformed values should be the 2.5% quantile of the standard normal distribution, which is minus 1.96, and this 97.5% quantile of the standard normal distribution, which is plus 1.96. So no matter what is the reference interval, what is the measurement technology, if you know the reference interval, you don't have to know whether this person was young, old, male, female, or whatever, how this was measured. You just need to know the reference interval, and after the transformation, you just have to look at this range, and you know whether the measured value is within this range or the transformed measured value is within this range or not. Just to show you some applications how this can help. So this is something I closely work together with the German Heart Center in Munich. And now if you take a look at the reference intervals for children, especially for newborns, they change drastically. You can imagine, I mean, the birth for the organism of the baby is a kind of catastrophe. You know, it has to start to breathe and everything changes. So this means everything goes like crazy, and the values change quickly. And you can see here, these are measured values from the German Heart Center of so-called NT-proBNP. NT-proBNP is a very good marker for adults if you want to like check for a heart attack and some things like this for heart failures. But you can see the newborns have extremely high values for NT-proBNP. You can see this on the left-hand side. So no adult will ever have such high values. They would be dead with these values already. But the newborn baby, you know, the heart has to start working hard and so on. Now, if we transform this, use the zlog transformation, the same values on the right-hand side, the green dots, you see they are like more or less in a constant range. So we have kind of applied continuous reference intervals here and could transform this. And also, if you now look at some specific case, so one child, they have often measured the NT-proBNP, the blue dots here on the left-hand side. In some sense, they seem to go down. They have to go down anyway. But if you transform them to zlog values on the right-hand side, the green dots, you can see that actually the values go up. The normalized values go up because, I mean, the reference intervals gets down and down over the age, and this is why you can see that the normalized values go up. So it's very difficult to follow like the whether the values really go down. I mean, they have to go down anyway, but will they go down strongly enough or not? And you can also see this, the red lines there. This is the ejection fraction, so kind of reflecting how strong the heart is working. And you can see the power of the heart is going down continuously. And actually, now they use this NT-proBNP in German Heart Center even for newborns, but they just use the zlog values because otherwise they change so quickly within the first weeks. It wouldn't make sense to really look at the direct values. Another issue. So now you have here, as is another patient. Now I think it's not a child. But you see here lab values from the patient. So you see this kind of file table, and even someone familiar with laboratory medicine might have some difficulty to see immediately what's going on. Usually you get it like this. So you just see some pluses and some minuses now there. So when this the value is above the range. So if you look at the second or the third and fourth column, UG and OG is for German Untergrenze, lower limit, and OG for Obergrenze, upper limit. So this is the reference interval. And you see then some values outside the reference interval. It's still, I think, quite difficult to see what's going on. Now with the standardization, you actually can transform the standardized values into colors. And then it looks like this. And now you see suddenly what's going on. So blue means the values are below or are low, and orange means that they are high or outside, I mean, above the reference limit. And of course, the stronger the blue, the lower the value, and the stronger the orange, the higher the value. And so what you can actually see is now you see the blood values went down, the hemoglobin again, the first line here, first row, it's going down and then it's suddenly going up. So actually the person had a surgery and lost blood, of course, and got a blood transfusion. This is why it's went down. And then you got the person got a second transfusion because the values went down, they go up again, and then they kind of go down again. And you can even see more here. This is maybe goes too far. You can see a liver congestion, which is quite normal after this kind of surgery. But you see immediately things that are happening, and I think it's easier for us to look at a kind of heat map or colored table than just looking at numbers and some pluses behind the numbers. So, and this is only possible if you have some standardized approach for this. Another application, which is more in my field, in statistics and machine learning, this is just illustration purposes. We have just submitted a paper for this where we show that in machine learning, you need to, also in statistics, often you need to, in multivariate statistics at least, you need to normalize your values to make them comparable. So, and this is just a visualization technique where we have normalized the values in the standard way, which is the left-hand side and the right-hand side. Actually, these are, well, the black dots represent blood donors, probably healthy blood donors. And then the other ones, the colored ones, they are hepatitis patients in different stages. So the red ones are the most serious ones. They are they have cirrhosis already. And we have taken, I think, 10 values from the lab that are related to the liver. And you can see if we just standardize the values in the usual way, as we do in machine learning, you still see some cirrhosis patients in the cloud of the healthy blood donors. So on the left-hand side, you can see some red dots there, cirrhosis patients. If we use the zlog transformation, all the cirrhosis patients are outside the cloud of the healthy blood donors. And of course, if you use more sophisticated techniques, neural network, they can distinguish these patients better from the other ones, or any kind of statistical methods, logistic regression, and so on. And the reason is very simple also, of course. You make the values better comparable. You are less prone to outliers, which you have if you have people who are very sick, because they can have very extreme values. And also, you don't need to learn the relation between age and sex and the corresponding values. So because normalize them already with respect to the reference intervals, which are different for the different age groups. So this is another advantage here. And there's also, at least in Germany, and not only in Germany, an initiative going on. So the so-called MIOs, the medical information objects, try to kind of standardize, not only laboratory values, but all the things that you have in medicine, in reports, and so on. And the zlog value is also part of this MIO. You can see it here. And we are also talking to international standardization organizations in this range of laboratory medicine to standardize these values. Yeah, so to conclude, what we want, or what we actually can achieve with this, we have an intuitive interpretation of laboratory results with respect to their common reference intervals. You see, it's always between the same range. You don't have to actually know what kind of analyte this is. So even you can see easily I showed you this kind of colored tables heat map. You can see which values are increased, which are too low immediately. This can be done worldwide. it remains lifelong, no matter even if the reference intervals change because the measurement technique has changed. It also makes it easier for laymen or for, let's say, doctors who are not so well educated or not so, let's say, trained in all the values, because no doctor can know the meaning of all the values, so they can quickly look at them and get an overview. And this is the advantage. And as I have seen, as you have seen, you can have a simple transformation into colors or graphics, which makes the interpretation even easier. It doesn't matter which kind of units you use. There's no confusion about the units or with the units based on or caused by the units. And so it's a kind of standardization if you use an electronic patient record. And as I said, it supports machine learning and statistical analysis, because you have a kind of standard where you don't have to take into account age and so on. It's already incorporated there, so it makes it much easier. And yeah, then I would at least have some acknowledgements. There are, of course, many more people involved, but those who are like closely working together with me on this topic, it's Georg Hoffmann, or there's one N missing, Stefan Holdenrieder from the German Heart Center. They're both working at the German Heart Center, and Sandra Klawitter, she's one of my PhD students working on laboratory values as well. And of course, we get some fundings there, and this I should acknowledge. And finally, I was asked to give my definition of global health research, and I think it's out of my expertise and out of my scope to really give a definition of this complicated topic. What is global health research? Especially since I'm, as Maeve already said, I'm not really a epidemiologist or a medical doctor. I'm a statistician. Of course, working together with medical doctors, epidemiologists. So I have looked it up in different websites, and I liked the definition of the Canadian Institute of Health Research, and also try to figure out whether I fit into this with what I've talked about. And yes, I do. I think it's the globalization. So if you want to put health records from different countries together, this standardization is definitely needed. It also helps, as I said, countries, low and middle income countries, where you have a shortage of, let's say, doctors and qualified doctors. It makes them easier to assess these laboratory values and come to a diagnosis or to make the right decisions. So I think this is one part where this standardization might help. Yeah, so thank you very much for your attention. And I think we have a short break in the outbreak rooms now, but I hand over to Maeve now.